Okay, welcome everybody to another exciting NELA nights. Tonight we're very fortunate to have with us Dr. Bimal, one of our fellows in training, Dr. Peter Toth, the former president of the NLA, and Dr. Daniel Wu, an expert neurologist, to discuss a topic that is something that your patients will always bring up and will always ask questions about, and so it's
Look, the
essential
peonies are
to
starting to open. The little
it's
pink
very
ones in the
important
bathtub.
to be able to answer these questions and to do so with information that that is useful to patients. So before we get started, we're going to be focusing on three primary things in the first part of the talk. So that's what the insights we've derived from lowering LDL to very low levels, how our clinical guidelines have developed alongside clinical trial outcomes. And then Dr. Bimal will present a case, which will be moderated by myself and directed towards our panelists, Drs. Toth and Wu, regarding a patient with FH. So over the last 30 years, there have been numerous primary and secondary prevention statin trials that have demonstrated that there is a log linear relationship between the LDL cholesterol achieved and the reduction in coronary heart disease events. With the TNT trial and then ultimately the IMPROVE trial and the FOURIER and Odyssey trials with evolocumab and alirocumab respectively, we are now at a time where we have seen us achieving LDL levels to levels that previously were not thought possible. So these are the FOURIER and Odyssey trials for evolocumab and alirocumab respectively, as we all know, showing that there continues to be event reduction alongside dramatic reductions in LDL cholesterol lowering on top of patients on maximally tolerated statin therapy. And the question then becomes, or a question that's commonly asked is, are we lowering cholesterol too much? So can LDL lowering be too aggressive and potentially compromise some of the functions of cholesterol? So I wanted to just first take us back to what is the function of cholesterol in our cells? So we all know that cholesterol is an important part of the myelin sheath. It's an important part of cell membranes. We all learned this, of course, in our early studies. And then obviously it's an important component of synthesizing critical hormones as well. So a question then becomes, if we aggressively lower LDL cholesterol, are we potentially compromising any of these important roles of cholesterol in our body? And the answer to that question is, actually, we are not. So LDL cholesterol is predominantly synthesized intracellularly or de novo, or interestingly, it's acquired from HDL. LDL is really an insignificant source of cholesterol for, in particular, steroid synthesis. So on the left, you see just a slide demonstrating that really cholesterol is a very tightly regulated process that is done intracellularly, or that is synthesized predominantly intracellularly. And then on the right, we have a slide that shows the rates of cholesterol acquisition from different sources. So as you can see, it's predominantly either through HDL, and these are looking at cholesterol synthesis from the adrenal and ovarian, as well as other reproductive glands. They're predominantly from de novo or synthesized intracellularly, or from HDL, and really LDL is not a significant source, not a necessary source for cholesterol synthesis. Now, of course, caution is warranted. So we weren't just going to kind of leave it on the basis of presumptive physiology. So the FDA in these studies required that the levels of ACTH and cortisol be measured amongst patients who were either not treated with in this case evolocumab, or were treated with evolocumab in the 4A trial. And what they found that there was no difference in cortisol and ACTH production, despite the aggressive LDL reduction. And even when we get to very low levels, so this was a pre-specified sub-analysis of the 4A trial, where they actually looked at patients with ultra low levels of LDL, so LDL less than 10, and they found that even amongst over 500 patients who achieved an LDL level of less than 10, compared to those who had an LDL level of greater than 100, there continued to be reductions in outcomes alongside the reduction in LDL, without any increase, as you can see on the right, in adverse events, nor any drug discontinuation. So LDL is being even lower is better. So then another important question that arises is, what about on the brain? Is there any concern for compromising cholesterol production, not in the peripheral nervous system in this case, but how about in the brain and central nervous system? So again, the cholesterol synthesis is predominantly synthesized de novo. The blood-brain barrier really prevents the uptake of, in general, of systemic lipoproteins from atherogenic lipoproteins. So, and also HDL, as opposed to these atherogenic lipoproteins like LDL, actually crosses the blood-brain barrier. It can provide a source, but even then, the brain predominantly synthesizes cholesterol de novo. So this is another slide demonstrating that that aggressive LDL reduction doesn't compromise any of our peripheral or central nervous system's ability to synthesize cholesterol. But again, caution is warranted. So they didn't just take this basic science and let it rest. They actually in the 4A investigators took 2,000 of the 4A patients as part of the Ebbinghaus study, and they looked at the cognitive function in amongst these patients, either randomized to placebo or to the treated arm. And this wasn't just mini mental status exams. These were pretty comprehensive battery of neurocognitive testing, including working memory, spatial processing, paired association learning, language fluency, reaction time, psychomotor speed. They looked at them at baseline, 6 months, yearly, and then 5 years out. And even amongst 661 patients who underwent cognitive testing with LDL levels of less than 25, there were no significant difference in these various measures of cognitive function. So again, showing that that in the clinical trial space, we're not seeing these differences when patients are brought to very low levels of LDL cholesterol in terms of cognitive function. So how about guidelines? How have guidelines evolved, or how are guidelines evolving alongside these findings? So I just brought in an example of the ACC's expert consensus decision pathway update in 2022 and what they did was their update included two different groups of patients with ASCVD. So there's a high-risk ASCVD group and a very high-risk ASCVD group. The high-risk ASCVD group included patients with clinical atherosclerotic cardiovascular disease, of course, with baseline LDL greater than 190, FH, high-risk diabetes based on the 10-year ASCVD risk calculator, as well as high-risk primary prevention based on the 10-year ASCVD risk calculator, and then evidence of subclinical atherosclerosis on imaging, and not even just with calcium scores, but also with just any evidence of atherosclerosis on, for instance, a chest CT, with lower targets for greater burden of disease. And then the very high risk group consisting of either having greater than or equal to 2 major ASCVD events or 1 major and multiple minor. Major ASCVD events would include a recent ACS, history of MI, history of ischemic stroke, symptomatic PAD, and then multiple minor, and I'll just go through a few of them, which would be prior PCI, diabetes, hypertension, CKD, smoking, etc. And for the very high risk ASCVD, so those again are those with the greater than or equal to 2 major or 1 major and multiple minor ASCVD high risk factors, they use a threshold of 55 for patients on a maximally tolerated statin. If their LDL was greater than 55, that was a threshold to add an additional non-statin therapy with either PCSK9 inhibitors or ezetimibe. For the ASCVD group that was not considered to be very high risk, but just high risk, and did not have FH, their LDL threshold was greater than 70, above which you would treat with either a PCSK9 inhibitor or ezetimibe. And even amongst and as we can see, since the most recent iteration of the formal guidelines are multi-society guidelines, including the ACHA and of course the NLA, where there was a threshold of 70, we've evolved both domestically and internationally from the ESC, European Atherosclerosis Society, as well, to have a lower threshold, including in 2019, they're recommending less than 40 if you had greater than 2 events in 2 years, all the way down to the Lipid Association of India, which is saying that for those with extreme ASCVD risk, which also they define as greater than 2 events in 2 years, of having a target, not a threshold target, of less than 30. So with this kind of with this background, we're going to move on to a case study and then discuss how some of these this information and knowledge can impact how we approach patient management. So I'm going to hand it over to Tia, and who will start to present her case.
Okay, I'm just going to share my screen. Okay, thank you, Dr. Hirsh. So here we have a patient who is 25 years old, and who a 25-year-old male who's a medical student with a family history of early heart disease and hyperlipidemia, who comes to clinic for the evaluation of high cholesterol. So his baseline LDL, which he recently found out, is 220. And due to lack of improvement through diet and exercise measures, he was started on atorvastatin 40 milligrams by his primary care physician. So in terms of lifestyle, he lives a very healthy lifestyle. He exercises, eats a plant-forward diet with lean proteins. In terms of medication, his only medication is the atorvastatin 40. In terms of family history, his mom has a baseline cholesterol LDL of 190 and has been on statins since her 40s. His maternal uncle passed away from heart disease at the age of 41 years. Review of systems are negative. His vitals, his BMI is normal. Physical exam was normal as well, and ECG was normal sinus rhythm with a heart rate of 75. In terms of labs, labs were significant for an LPA that's slightly elevated to 85 nanomoles per liter, He had a total cholesterol of 295 and an LDL of 219. And this is prior to starting the atorvastatin 40. At the 3-month follow-up, patient reports that he wasn't able to take the medication every day due to brain fogginess and forgetfulness, which is interfering with his studying. So a decision was made to switch to atorvastatin 20 milligrams oral daily. 8 weeks after starting atorvastatin 20 milligrams, his LDL decreased to 130. He did take the medication this time every day, and he tolerated it well. And the decision was made to continue this dose. At age 35, given the family history of early heart disease and hyperlipidemia, a decision was made to do further workup with a CT coronary angiogram. And the CT coronary angiogram showed a 20 to 39% non-obstructive calcified plaque in the proximal right coronary artery, which is the dominant vessel. All other vessels had non-obstructive disease and diffuse mild calcifications. The coronary artery calcium score was 49. Because of this result, a decision was made to add ehrlichimab 150 milligrams biweekly to reach an LDL of less than 70, along with the atorvastatin 20. So at 2 months after starting the PCSK9 monoclonal antibody and also continuing the atorvastatin, the patient's LDL was 3. So our discussion questions here are, is the patient's LDL very low right now? Should we consider discontinuing the atorvastatin 20 milligrams? Or should we reduce the ehrlichimab to 75 milligrams biweekly?
Okay, thanks very much, Tia, for presenting that case. Okay, so everyone, please feel free to type into the chat if you have any specific questions. Otherwise, I can certainly moderate with some pre-prepared questions. So just building off of the presentation I presented and then the case here, I'm going to ask Dr. Toth to rejoin us and say and answer the first question. Is the patient's LDL currently too low?
Well, actually, Ben, I would tell this patient to go light candles in church and thank God that he was provided with a couple of interventions that allowed a patient with FH to get to 3 milligrams per deciliter. Is it too low? And, you know, the answer is no, because number one, if you look at Framingham data, when LDL is between 0 and 10 in terms of milligrams per deciliter, there's still around 300 nanomoles per liter of LDL particles in blood. So there's plenty of LDL around. And what you're doing is you're profoundly shifting the chemical gradient away from the vessel wall, which is going to be highly protective. And you'll also notice that although he complained of brain fog on the 40 of atorva, on the 20 of atorva plus the alirocumab going to an LDL of 3, he had no cognitive complaints. So really, you can't correlate the magnitude of LDL reduction with his cognitive symptom. And he already at the tender age of 25 has established coronary disease. I would park him right here.
Yeah, I fully agree with that. And there was a question in the chat, why not ezetimibe before PCSK9 inhibitors? Personally, I think that a 35-year-old, that's a very good question, by the way, and it's not unreasonable to start with ezetimibe, but a 35-year-old who's already developing a fair amount of plaque, who's living a pretty healthy life, and uh, and it has, I think the LDL was 130. Is that right? Beforehand to you?
Sorry, yes. Yes, it was
Yeah.
130.
So I would be very aggressive, and I agree with Dr. Toth in saying that parking that patient at LDL-3 is really great. I don't think I would go to ezetimibe first, although it's not an unreasonable approach.
Yeah, and I agree. I would not go with the ezetimibe first because in this day and age, given how young he is and the fact that he has established plaque, you want to blow his LDL through the floor. So I would be very comfortable keeping him at 3.
Very good. Okay. So let's go on to the next question. T, is it possible to bring it back here? Okay. Should we consider discontinuing the atorvastatin 20 milligrams? Or I'll kind of combine that with the third question, actually. Would reducing to 75 milligrams biweekly be appropriate? So, Dr. Toth, once more.
I would never discontinue the atorvastatin. I would not discontinue a statin in any patient with established coronary disease ever, if they're
Right.
tolerating it. This is very fundamental to lipid management, to management of coronary disease. So no, I would not ever discontinue the atorva. And as I said, I like the fact that we took the LDL where we took it, because in the year 2024, the going mantra is lower is better, but lowest is best. And so I would not cut back, especially since he's tolerating the medications and he has disease.
Very good. And I agree completely. I think lower is best in this case. And obviously we'll keep him on the atorvastatin, which really should not be discontinued, even if the LDL is 0, because of the pleiotropic effects of statins, and it's always first-line therapy. An interesting follow-up, which I think is actually really quite an interesting comment from Thomas Dayspring to everybody. So, and I'm going to pose this to both Dr. Wu, if you could, I don't know if you're on the screen and can join us, but I'm going to pose this to both Dr. Toth and Dr. Wu. So this one is that it's really pretty interesting. It's saying that astrocytes synthesize most of cholesterol that is trafficked to neurons in the brain, created ApoE HDL particles. So astrocytes use the block pathway to make cholesterol go through desmosterol. Ultimately, I guess what this person is what Thomas is trying to say is that could it be that atorvastatin is suppressing brain cholesterol synthesis and not necessarily PCSK9? And that's kind of an interesting theoretical question, because we know that atorvastatin may cross the blood-brain barrier. PCSK9 antibodies are quite large and do not cross the blood-brain barrier, generally speaking. So, Dr. Wu, if you're on, do you have any comments on this?
Sure. So loved all the research and epidemiology. I think there's a difference between people who are high in cholesterol and you lower them because they've got a lifetime of having had a high cholesterol. And I would say that the epidemiologic evidence in neurology is pretty clear that ultra low cholesterol does increase the risk of certain conditions, such as brain hemorrhage. It can worsen Parkinson's disease, and people who have other neurologic disease, ultra low cholesterol is associated with some bad things. However, in a general population, and certainly this person who has had familial hypercholesterolemia and so forth, I agree with you that their greatest risk of morbidity and mortality is their heart. And I agree that you should lower this person's cholesterol. But there is a lot of epidemiologic evidence. Statins do cross the blood-brain barrier. They do. There is some evidence. It's not very strong, but there is some evidence that it might reduce a little bit the brain's production of cholesterol, certainly that pathway. But there are other pathways in the brain that they can make cholesterol up with. And so from that standpoint, I think 20 milligrams, I think would be fine. I also like all the other pleiotropic effect that atorvastatin has. Very often when a patient has the brain fog as a neurologist from a statin, it's almost always nitric oxide release from a statin, not the cholesterol level. And so it's the pleiotropic effects the statins might have on availability on the what's called the neurovascular unit. But not so much the actual cholesterol level. And so, again, from my standpoint, I'm not so worried about the level so much as do they have underlying neurologic disease? Many of the studies that have normal patient populations with high cholesterol that are lowered, they had a lifetime of high cholesterol. And cholesterol in the brain lasts way longer than anywhere else in the body. It's one of the largest stores of cholesterol there is, but it just doesn't metabolize and go away as well. So I kind of feel like 5 years is a little short, but at least in the short term, I would say, yeah, there's almost no effect on a normal, healthy brain. But if somebody does have if somebody does have a underlying neurologic disease, I don't know. I have to admit, I'm a little more worried about ultra low levels. I'd want to know what the risk benefit ratio is compared to their neurologic disease progression compared to their heart disease. If somebody has zero heart disease and they have some neurologic condition, I'd be even more hesitant to lower them to ultra low levels.
Yeah, that's interesting, Dr. Wu. When we talk about a lot of these studies, I think we have to pay very, very close attention to how the data were adjusted, what risk factor covariates were adjusted for, because often they are inadequately adjusted. And I think it's amazing that in some recent years, let's just take one example of Alzheimer's dementia. All the risk factors for atherosclerotic disease, namely elevations in atherogenic lipoproteins, hypertension, chronic elevations in systemic inflammatory tone, insulin resistance, diabetes, they're all risk factors for Alzheimer's dementia. And we don't know if in midlife lowering LDL impacts future risk for Alzheimer's dementia. But most certainly, this is something we have to pay very close attention to. And I know you mentioned hemorrhagic stroke. Those data just don't line up. Most recently in Fourier and also in Odyssey outcomes, they looked very, very closely at whether or not there was a signal for hemorrhagic stroke. And even when LDL was ultra low at less than 10, there was no signal. And a lot of other studies are now showing that too. Now, there's a difference. And, I've looked recently at this, and for some reason, in Asian populations, there does appear to be a signal for hemorrhagic stroke, but not so much in Caucasian or Black populations. So, I don't purport to be an expert in neurology, and I know you are, but I think newer looks at the data certainly don't support this widespread evidence that low LDL somehow induces hemorrhagic stroke, and actually in the two atorvastatin trials, and most recently the one by Pierre out of Paris, where they looked at LDL less than 100, less than 70, there was absolutely no signal for hemorrhagic stroke in either treatment arm. So I don't know. It's interesting.
So these are a lot of interesting points. We covered a lot there. Just going back to it, Dr. Wu, are we potentially confusing cholesterol in the peripheral circulation and cholesterol in the brain? You were saying that statins cross the blood-brain barrier could potentially suppress synthesis of cholesterol in the brain. So is this a peripheral issue or a central nervous system issue? Are you able to unmute? Dr. Wu? Okay. I guess I'm not sure he can hear us. Dr. Toth, any thoughts on that?
Ben, repeat the question.
So Dr. Wu was mentioning that it's possible that statins do reduce brain cholesterol or synthesis of cholesterol in the brain. Are we potentially confusing reduction of cholesterol in the periphery or reduction of cholesterol in the brain? And is that a potential reason people might be concerned for cognitive side effects?
Well, I think one potential response to that is when you look at hydrophilic as opposed to lipophilic statins, there's no difference in so-called neurologic side effects. So one class can cross a lipid barrier, the other one cannot. And we know that there's no statin pump along the blood-brain barrier. So I am not convinced that that is a meaningful mechanism. And when you look at cholesterol in the brain, it's highly structural. Oligodendrocytes are producing cholesterol for myelin formation. As Tom Dayspring pointed out, astrocytes are producing cholesterol for neurons. And there's a lot of exotic HDL metabolism. There's ApoJ, ApoL, ApoM HDLs in the brain. So there's a lot we need to learn about the lipoprotein trafficking and lipoprotein physiology within the brain.
I'm so
Right,
sorry.
so-
I finally got audio back. Were you guys asking me a question?
We were just sorry, Dr. Toth, were you about to say something?
Yeah, I'm done.
Okay. No, we were just discussing whether or not statins are truly crossing the blood-brain barrier, and whether there is any meaningful effect of statins lowering cholesterol in the brain, and maybe we're potentially confusing it with lowering LDL cholesterol in the peripheral circulation.
Yeah, there was a study about how your brain metabolizes. I forget how it is, like different kinds of sterols, and it's can only come from the brain. And those that were on statins were producing less of it. That's the best evidence that I've seen on it. But I guess I don't know that I've seen like a tag statin cross the blood-brain barrier or anything like that. But it would, I think there's a lot of epidemiologic evidence. Again, it's just epidemiologic, it's not randomized trial evidence that it's associated, for example, with worse Parkinsonism. I'm not so sure about Alzheimer's, but and then again, my point about the very low LDL was a lifetime of low LDL is a risk for hemorrhagic stroke. I've never seen a study where somebody at high cholesterol was lowered to very low levels. I've never seen a study that said that was associated with an increased risk of brain hemorrhage.
Okay, just to go back to Dr. Toth's point, I think there are higher rates of neurodegenerative disorders, of course, with uncontrolled risk factors, much more so than necessarily statin therapy, I would imagine, right? Such as controlled diabetes, smoking, high LDL. All of these things are also associated with neurodegenerative disorders such as Parkinson's, Alzheimer's, correct?
Yes.
Yes. No, I was talking about a study where those that had been, yes, I agree with that. Of course, we definitely want to do good science too. I'm just saying that.
No. That's why you're here. We to offer a different perspective. So
yes, after controlling for all of those things, statin use was associated with some worsening of neurodegenerative disease. Other people have been commented it's been associated with MCI. It's been associated with other things, and but you're right. We have to control for the fact that is the statin, or is the fact that they had high enough cholesterol that they were placed on a statin? Is high cholesterol really the risk factor, and not really the use of the statin? But everyone's done their best to try and control for those things. Really, you need randomized trials. But my thing about it is that your brain's cholesterol lasts a long time. You'd have to really have a long study to see And again, heart disease is the #1 killer. I really think that I would only be cautious in settings where is the prevention of that making somebody worse? But somebody as young as this person, who's obviously their biggest risk is to get to the point they get have dementia or something like that. And so I agree wholeheartedly with the approach that was taken on this particular patient.
Very good. Very good. So let me just take a step back and let's pretend we're all trying to speak to a patient here. Many patients come to us and say, I mean, it must be for me at least 3 times a day, and say, well, I don't want to take a statin because, you know, I'm going to get dementia. and you know, I don't want those side effects and you know, not least, you know, the muscle aches. How do you why do you think it is that patients in this story of dementia is so entrenched in people's minds, and you know that
I'm not aware of
that
that.
it's
I have the opposite problem, but that must be a very cardiologist thing to face. From my side of the fence, I'm trying to convince people about the need for the statins and so forth. I actually do think that statins in particular do have a lot of pleiotropic effects, and for stroke risk, for example, ischemic stroke risk and so forth. The benefits to stroke prevention seem to be greater than you would expect from just the amount of LDL that's been lowered. So I do believe in that aspect, and I love the idea that you guys are going to continue the statin. And but as far as dementia risk goes, I think it's pretty safe to say from my standpoint that if you have high cholesterol for a lifetime, even lowering it to very low levels, it would take a long time for your brain's cholesterol to get to a really low level. There's no way of really measuring the brain's cholesterol. I'm trying to find ways, but it would take a really, really long time for that to happen because your brain's cholesterol just lasts so much longer.
and
Yeah,
I'll get
that's
back to that
what
point about measuring brain cholesterol, but just giving it to Dr. Toth. Dr. Toth, why do you think it is that so many people have this narrative that that really that statin therapy in particular is going to potentially cause them to have cognitive dysfunction or dementia?
Well, it's coffee clatch. It's garbage on the internet. It's people discouraging other people from taking a statin because your doctor's trying to poison you. You know, years ago, if you showed someone a pill that was life-saving, reduced all-cause and cardiovascular mortality, reduces your risk of being split open like a watermelon for a bypass surgery, reduces your risk of stenting, on and on, they'd kick the door down for it. But now they go, you know what? I don't think so. Now, you know, it's I try to explain to patients very, very carefully that the most important side effects are the fact that you're reducing mortality and reducing morbidity. Those are important side effects. And if you get any other side effects like the muscle aching or the so-called brain fog, let me know. And I don't get a lot of pushback. I mean, I'm in a rural area in Illinois, and patients here listen. And I feel sorry for you big city slickers who get a lot of pushback, but it is what it is. So I think we need to emphasize more every time we see the patient what the good side effects are.
Absolutely, absolutely, and also, so I think it's sometimes I feel like the more educated the patient, the less likely they are to, or the more likely they are to feel like there's going to be myalgias or cognitive dysfunction. So it is interesting that that we do seem to have that conversation, and at least in New York City and Long Island. So just shifting gears here, it seems like the lipid community is trying to get their claws on the PCSK9 protein for the last decade. We are attacking it with antibodies. We are preventing its production with RNA and antisense inhibitors, and we are gene editing it out. Dr. Toth, do you think there's any concern with potentially shutting down the function of PCSK9 protein?
Well, actually, there was a paper published a month ago, which was based on the UK Biobank. And now I'm just talking about fetal development, okay? PCSK9 doesn't just regulate lipoprotein receptors like the ApoE receptor, the LDL receptor. It is intimately involved in fetal development, in bone formation, in cardiogenesis, even vasculogenesis. It has a broad range of function. And we don't completely understand PCSK9 yet. It'll be years. I mean, just punch in PCSK9 into PubMed, you'll get thousands of papers and you will not believe what you see. It touches so many things. So, to completely gene edit it out, no, I don't think we're ready for that.
Yeah, and it seems like it's happening with this CRISPR technology. So I guess a counter view would potentially be that for patients with loss of function mutations in the PCSK9 gene or protein, that they live completely normal lives without any ostensible effects. So that would be one of the counterpoints there.
Yeah, and we've characterized 5 of them in the world.
Fair enough.
Not very many, and it's true. They do tend to be long-lived, but I think we have to be careful.
That's true. I think it seems like we're really tumbling towards gene editing of PCSK9, and we don't have yet all the data and not on the full functionality of the protein. So that's interesting. We got a question from the chat, Dr. Wu, about the possibility that we can measure brain cholesterol synthesis through the 24S OH. I'm guessing that stands for, I don't know what that stands for.
Yeah, that is right. That's exactly what I was talking about. That's the study that showed that statins seem to suppress brain cholesterol synthesis.
So is that a reliable measure? Why aren't we measuring that more if we're concerned about this? Or is there?
I'm not sure.
Is there?
I know the answer to your question. I don't actually think it's a very easy thing to measure, but I don't know the answer to your question.
Yeah, no, it just it's an interesting thought. I think probably it's more academic, but I guess my question is there any reliability to that? So some studies have showed depressed levels of 24S-OH cholesterol, and do you think that's actually a reliable marker?
It's been a while since I read the paper, but yes, when I read it, I was quite intrigued because it is something that seems to be, it's not confused with other kinds of cholesterol sources. It's produced by the brain. And so seeing that level and then putting on a statin, seeing it lower, I don't know what else to call that. That seems pretty convincing. It seems like a cause and effect. But it has been a while since I looked at that paper. Perhaps you can unmute the person who made the comment.
Yeah,
I don't know.
might need some help on that. So the I guess the question I would then say is how do we extrapolate that, right? So let's say in fact that level is suppressed. What is it? What does that actually mean? Does that mean that the brain is short of cholesterol?
No.
As you
I'm
said,
just saying that,
as you said, it was very saturated, throughout the lifespan, and so it probably doesn't reduce cholesterol stores to any meaningful level, I'm guessing.
I don't know the answer to your question. I think it would have to be if it does, it would take a very long time to have any meaningfully low levels.
Right.
And as I said, I'm not aware of the association with like dementia or anything like that, but I do know in Parkinson's disease, for example, statin use has been associated. And, I'm a hemorrhagic stroke guy, by the way. So I don't know. I feel pretty confident that, again, a lifetime of low LDL really is a risk. Epidemiologically, I don't know what to say. I don't think that somebody who's had high cholesterol and you're lowering the cholesterol that it's associated with any risk. And I just want to make sure I've said that clearly, that I've never suggested that we're getting somebody to ultra low levels raises their risk in 5-10 years. I am curious about the long-term effects of it, but I'm sorry, Dr. Dayspring is unmuted and I think wants to, probably knows more about this than I do, so I'll shut up.
Yeah,
Dr.
thanks
Dayspring?
for answering my questions. 24S-hydroxycholesterol is a metabolite of cholesterol produced in neurons that can cross the blood-brain barrier. Once it does, it jumps on the nearest lipoprotein and is brought to the liver for further catabolism. But it's easily measurable in the serum. In fact, the New Amsterdam people, because they're interested in what obicetrapib does to dementia, is measuring 24S-hydroxy in a subsegment of their patients. So if you do reduce cholesterol synthesis in the brain with a statin, you will see a reduction of 24S, means sinister. It's describing an isoform of the 24-hydroxycholesterol. So that is a useful biomarker. Similarly, the astrocytes, which make most of the cholesterol for the neurons, oligodendrocytes make cholesterol for the myelin, not for neurons. And the astrocytes go through the block pathway, which is the penultimate sterol in that is desmosterol. There is a nice 2 studies showing central spinal fluid desmosterol correlates extremely well with serum desmosterol. And if you therefore measure serum desmosterol, you have a pretty good marker of brain synthesis. And in that study, the people who had low cerebral spinal fluid and serum desmosterol had a significantly increased incidence of cognitive impairment and Alzheimer's disease. So this needs a lot more study. And as Peter mentioned, we're just tippy-toeing into the brain for the first time now to get a handle on this. But we do have good markers. And the last thing I'll say is all statins can cross the blood-brain barrier, even the lipophilic. That's been shown now. A long time ago, it was thought only the hydrophilic get in. And in some of them, desmosterol goes down. I know that. I'm in a practice where we monitor this on everybody. And in people with brain fog, they often have low desmosterol. So that is a one, other thing is there too much cholesterol in the brain is associated with AD. So I believe some degree of cholesterol synthesis inhibition in the brain is probably wise, but you never want to over-suppress it because, as you noted, the brain has no other source of cholesterol other than synthesis. Cholesterol cannot pass from plasma lipoproteins into the brain. So this gets very, very interesting. I would suggest that next time you talk on this, you bring in Richard Isaacson, who's probably the world authority on dementia and Alzheimer's disease, ran the Cornell Clinic with Kellyanne Otis, who has picked up his slack. And they have a lot of data on these markers in brain, and they measure it on all their patients that they're following in their clinics. So it's a very interesting topic nowadays, and we have much to learn. But these markers are available, certainly for clinical trials, and anybody in the real world can measure desmosterol, sending it to the appropriate lab. Desmosterol is not a peripheral synthesis marker. Lithosterol occurs in the peripheral cells, the Cam-Dutch-Russell pathway. So I'll shut up.
No, thanks.
You don't have to shut up, Tom. Tom, my only response to that is, as Ben showed us in Ebbinghaus, okay, granted, it's 2.5 year study. They noted no increased risk for the development of cognitive impairment. The scores with the cognitive battery remained very stable. But I think one of the most impressive things about Ebbinghaus was when they sent out self-assessment surveys to all the patients. Even the patients, which is unusual, even the patients did not note any change in their cognitive capacity across a broad spectrum of executive function. So I am not at all sold that.
Peter, PCSK9 inhibitors do not inhibit brain synthesis. Only statins do. Bempedoic acid doesn't, and ezetimibe doesn't.
Yeah.
So
no, that's fine, Tom. What I'm talking about now is just pure LDL reduction.
Yeah, I'm all for that in the periphery, but I think you do have to be careful about suppressing cholesterol synthesis in the brain. And the only drug that does that right now is statins.
So I don't want to take us too far away from, the right now. I think this the topics of the various forms of brain cholesterol and how we can measure it, and whether or not that's, it seems very intriguing. But it does seem like there's a lot more data that we need to follow to form any meaningful conclusions. Because right now the data that we're seeing hasn't demonstrated any meaningful change in clinically measured um, cognitive task and function. So I think that I still would look at the bigger picture of lowering risk factors with statins first and foremost. And then it's certainly very an interesting topic to maybe discuss it on a separate night about whether or not statins further reduce these other types of cholesterol that we can measure.
And Tom,
Peter?
I'm just going to add one more thing, Tom. Remember, in Ebbinghaus, half the patients were also on high dose, high potency statin. Well, all of them were. So they were on high dose Rezuva, high dose Atorva, and they did not see any increase in dementia.
But do we know how many dropped out in that trial before they even were put on the PCSK9? Because the minority might have had some brain fog, and therefore they were not on high dose statins.
Okay,
so
you can try to argue around it, Tom. Come on.
Peter, I'm going to send you the articles when we hang out. I think you really have to get into this a little bit further also. Look, you're the guy who taught me everything, so I'm not trying to disrespect you.
No. Yeah, send it to me, Tom.
Very interesting. Very interesting. I think this we might have to have a sequel of this, but ultimately, what we do know is that lowering LDL cholesterol substantially reduces cardiovascular disease events. High LDL, as similar to other risk factors such as smoking, uncontrolled diabetes, hypertension, is associated with a greater risk of cognitive of degenerative disorders such as dementia and Parkinson's. And so I think I just want to everybody to remember that that's really the bigger picture here. But it is interesting to discuss these topics. Dr. Wu, you had a comment?
Just that, the evidence is great. I think that's, again, I keep making the point, if you have high cholesterol, at least in the short term, 2.5 to 5 years, there's no evidence that lowering the cholesterol is going to cause you any progressive neurocognitive development. However, I still think it's possible that over many, many, many years, and I wouldn't say for PCSK, I agree with Tom that's just serum cholesterol. It's not your brain's cholesterol. But I'm not sure that you guys can, I don't know what to say. I don't know that it's definitely true that over a lifetime of having very low LDL, that we know the answer of that if you've lowered it. So that's all I'm trying to say. The brain's cholesterol is important to the brain's health. And it's one of the things that we do think is important for neuronal function, but the brain makes almost all of it. I don't care about the little tiny amount that crosses the blood-brain barrier through different mechanisms. There are a few mechanisms, but it's such a tiny amount. So again, I think that the evidence is very clear that lowering the cholesterol, peripherally is probably very safe.
Right. So, and just to bring us back to the point of Dr. Toth, I think we do have several studies, even with pravastatin, looking at 30 to 40 year periods, where I get your points are well appreciated, but just to bring our back to the central theme, that's that aggressively lowering LDL cholesterol over several decades. With statins, we have numerous primary and secondary prevention studies demonstrating at least that we would significantly reduce cardiovascular events. And the most important side effect, as Dr. Toth mentioned, was reduced mortality and reduced cardiovascular events. Any final words, Dr. Toth? I'll let you finish us out.
Well, I think this was a very robust program tonight, and I really enjoyed it. I think the level of participation by everyone was just wonderful. And I learned a lot from everybody. And I think we have a lot of take-home points here tonight. And I guess I'm just going to keep scouring the literature and keep studying this.
Well, I certainly agree. This is very intriguing, and I think we need to have more neurologists on our panels. But very interesting. Thank you guys for joining another exciting Neela Nights, and look forward to the next one. I hope everyone has a good evening.
Great job, Ben. Thank you.